trigeminal neuralgia. We have all seen scenes like this from cartoons and movies. What if I were to tell you that it's not all cartoons, and there are people in the world who suffer from a condition that causes them to feel like this? Today's video focuses on enlightening you about the same. I recently came across a patient sitting in my outpatient department covering the left side of his face with his hand. On speaking to him, I noticed he had to pause after every 3 to 4 words. He explained it was because of severe, piercing, intermittent, shock-like pain on the left side of his lower jaw and teeth. The pain was triggered when he spoke, shaved, washed his face, ate food, brushed his teeth, and with light gusts of air. I did not find any pathology on a thorough intraoral and extraoral examination. I felt it was a case of trigeminal neuralgia, or Fothergill's disease, affecting the mandibular division, and referred him for an MRI scan. The report suggested a close association between the superior cerebellar artery and the trigeminal nerve on the left side, confirming my diagnosis. Let us revise our neuroanatomy.
Pop quiz.
Let us step out of the case and learn about trigeminal neuralgia. It is a chronic facial pain condition that affects one or more divisions of the trigeminal nerve or the fifth cranial nerve. This nerve has 3 major branches: the ophthalmic nerve, the maxillary nerve, and the mandibular nerve, with the lower 2 being most frequently involved. In my patient, it was evident that the mandibular branch was involved. Multiple branches can also be affected. Moving on to the etiopathogenesis. Compression of the trigeminal nerve by nearby blood vessels, destroying the myelin sheath that surrounds it, is the most likely cause of trigeminal neuralgia. Myelin is essential for the rapid and smooth transmission of electrical signals, so we can respond to situations fast and efficiently. The most common blood vessel involved in the compression of the nerve is the superior cerebellar artery. We had seen this in my patient's MRI report too. Some of the other vessels that could be involved are the anterior inferior cerebellar artery, vertebral artery, and superior petrosal vein. Other causes of trigeminal neuralgia are tumors, cysts, trauma, viral infection in the region, and systemic diseases such as multiple sclerosis. Sometimes cases are idiopathic. Based on the causes, trigeminal neuralgia is classified as classic, secondary, and idiopathic respectively. Let us discuss the clinical features in depth. The 3 main characteristic features of trigeminal neuralgia are the paroxysmal sharp-shooting electric type of pain, the unilateral presentation of the condition, and the trigger factors causing the pain. All these were observed in the case we saw. But we must also be aware that although rare bilateral cases can also exist. Paroxysmal pain attacks begin and end abruptly, lasting from a fraction of a second to 2 minutes. At times, along with this, a continuous burning or throbbing pain exists. There are conditions accompanied by spasms and twitching of the ipsilateral facial muscles, hence the name tic douloureux. Another feature observed is the presence of a refractory period between attacks, during which trigger factors do not cause pain. Recent studies suggest that 18% of trigeminal neuralgia cases experience a dull continuous pain for days to years, which later progress to its typical presentation with flashes of pain. Thermal stimuli are the main trigger factor. This condition is called pre-trigeminal neuralgia. Moving on to the management of trigeminal neuralgia. Carbamazepine is the drug of choice, So I prescribed my patient a low dose of 100 milligrams after food twice a day. After a week, I increased the dose to 200 milligrams on alternate days. Although this helped relieve my patient of his pain, I advised him to continue with the medication. In cases that do not respond, a gradual increase in dose is continued to a maximum of 1200 mg per day based on the response and side effects. Some of the common side effects of carbamazepine are lightheadedness, confusion, dizziness, vertigo, blurred vision, and vomiting. Unfortunately, my patient came back with vertigo and vomiting, because of which I prescribed 300 milligrams of oxcarbazepine. Another drug that can be used as an alternative is gabapentin. Baclofen and lamotrigine can be used in combination with the other drugs. When patients do not respond to the pharmacological mode of treatment, surgery is the next option. Surgical procedures include microvascular decompression, carbonite stereotactic surgery, and percutaneous trigeminal rhizotomy procedures. Microvascular decompression involves a surgical separation of the blood vessel that causes the compression of the trigeminal nerve. This is the most cost-effective surgical approach. Studies have shown that 5 to 10% of the patients undergoing microvascular decompression end up with complications such as hearing loss, meningitis, cerebral fluid leak, and sensory changes. 30 to 40% of the cases may experience a relapse after 10 years. The second surgical procedure in our list is gamma knife stereotactic radiosurgery, which is another minimally invasive technique. This procedure aims at delivering focused radiation of around 70 to 90 gray dosage to the nerve at the point of the vascular compression. It provides an excellent initial pain relief. Moving on to the third procedure on the list. The percutaneous trigeminal rhizotomy includes procedures such as radiofrequency rhizolysis, glycerol injection, and balloon compression. These modalities result in excellent initial pain relief, but are associated with high rates of recurrence and complications.
Pop quiz.
Radiofrequency rhizolysis involves introducing a needle through the foramen ovale, heating a part of the nerve and desensitizing it, thereby interrupting pain information to the face. Balloon compression involves injuring part of the trigeminal ganglion by inserting a balloon and inflating it. Introducing glycerol into the injured fibers of the nerve inactivates the improper pain signal transmission. In secondary trigeminal neuralgic cases, the underlying pathology is simultaneously addressed. Let us discuss other conditions that present with the typical characteristic pain of trigeminal neuralgia, which I had considered and ruled out for my case. These are postherpetic neuralgia, cluster headaches, paroxysmal hemicrania, SUNCT syndrome, and glossopharyngeal neuralgia. To begin with, I ruled out postherpetic neuralgia since my patient did not have a positive history of shingles. Moving on to cluster headaches, pain occurs once a day daily at the same time and typically involves the ocular region, whereas in this case there were trigger factors that caused the pain in the lower right jaw region. Next on the list is paroxysmal hemicrania, which I ruled out with a thorough history that did not reveal a seasonal pattern of attacks. It also involves autonomous signs such as conjunctival lacrimation, nasal congestion, rhinorrhea, facial sweating, eyelid edema, miosis, and ptosis, none of which were present in this case. Patients with SUNCT syndrome experience pain mostly involving the periorbital or orbital region, and autonomic issues similar to those of paroxysmal hemicrania, both of which were not seen in the case we discussed. The last condition I thought of was glossopharyngeal neuralgia, where the patient feels a scratching or foreign body sensation in the throat, and pain attacks are milder than those of trigeminal neuralgia. Since my patient did not show the typical symptoms of glossopharyngeal neuralgia, I was able to rule it out. Here is the definition of trigeminal neuralgia and key points for you to remember. Please feel free to take screenshots. With this, we come to the end of this video. We hope you had fun learning with us.